We have this collective illusion about modern medicine. We tend to view it as an exact science, almost like engineering.
Right, a clean binary system.
Exactly. I mean, you break your femur, the imaging shows the fracture, a surgeon inserts a titanium rod of a very specific diameter, and the mechanical problem is solved. Broken, then fixed.
Yeah, but the moment you pivot away from acute trauma and step into the realm of chronic systemic conditions, specifically cardiovascular disease, well, that illusion of precision just vanishes.
It really does. Suddenly, we aren't looking at an engineering schematic anymore. We're looking at a therapeutic landscape that is surprisingly murky.
It is incredibly murky. We are dealing with biological systems that are constantly in flux, constantly compensating for whatever interventions we throw at them.
Totally. And nowhere is that more obvious than with cholesterol management. I mean, we've all heard the endless messaging about LDL, the quote-unquote bad cholesterol.
The universal mantra for decades has basically been that lower is always better.
Right. But if you are someone who already has established heart issues, a very pressing, very practical question arises. Exactly how low should you try to push it? Like, is lower infinitely better? Or is there a biological floor where the human body simply stops benefiting and starts experiencing toxicity?
And for a remarkably long time, the medical community just didn't have a definitive numerical answer to that. I mean, we've been operating on a blend of observational data, extrapolated trends, and expert consensus.
Educated guesses, basically.
Exactly. Highly educated guesses, but guesses nonetheless. Today, though, we're looking at the hard data that replaces the guesswork.
Welcome to today's deep dive. We are thrilled to have you with us because our mission today is to unpack a highly specific, incredibly revealing superiority trial conducted in South Korea. The researchers basically took two very different, fiercely debated medical strategies for managing LDL cholesterol, threw them into the ring together, and tracked thousands of patients to find the absolute optimal target.
And we are going to extract the real-world clinical aha moments from this source material. I mean, it's a dense, peer-reviewed study packed with hazard ratios and confidence intervals. But our goal is to translate that data into mechanism.
Yeah, we are going to look at what these specific lipid targets actually do to the physical structure of your arteries.
Yeah.
Okay, let's unpack this. Before we get into the heavy hitters of this South Korean trial, we need to understand the physiological battlefield.
Right, the context is everything here.
Because the source material explicitly states this trial is focused entirely on secondary prevention in patients who already have atherosclerotic cardiovascular disease.
Yeah, and the distinction between primary and secondary prevention is the entire foundation of why this trial exists. Primary prevention is treating someone who has risk factors, maybe elevated lipids, maybe hypertension, but they haven't actually suffered an event yet.
So their blood vessels might be starting to show wear and tear, but the architecture is mostly intact.
Exactly. Secondary prevention, on the other hand, means the patient has already had a cardiovascular event. They've had a myocardial infarction, an ischemic stroke, or, they've required a stent.
Right, the stakes are totally different. I mean, primary prevention is doing routine maintenance on your house to prevent a leak. You clean the gutters, you inspect the flashing.
That's a great way to look at it.
But secondary prevention is like reinforcing the roof after a Category 5 hurricane has already smashed through it, flooded your living room, and compromised the load-bearing walls. The plaque buildup in the arteries is already severe, established, and highly unstable.
The biological environment in secondary prevention is essentially a state of chronic systemic alarm. The endothelium, the inner lining of the blood vessels, is already deeply dysfunctional.
So it's actively inflamed.
Very much so. The immune system is constantly interacting with these established plaques, creating localized inflammation. You aren't just trying to prevent a problem, you're trying to pacify a violently active disease process.
But wait, if we already have extensive guidelines from major medical societies like the American Heart Association or the European Society of Cardiology for secondary prevention, doesn't that imply the science is settled? Like, why are the researchers of this trial explicitly calling the existing evidence limited?
Well, if we connect this to the bigger picture, that assumption is one of the biggest pitfalls in how we consume medical information. A published guideline does not automatically mean we have head-to-head randomized trial data, perfectly isolating that specific target.
Right, really. I think most people assume guidelines are basically ironclad laws of physics.
Not always. Historically, guidelines for LDL targets were often formed by consensus panels. Experts would look at trials that compared a high-dose statin against a low-dose statin, or a statin against a placebo.
Okay.
And they saw that the groups taking the heavier drugs had fewer heart attacks, and they noted the average LDL in that group. From there, they extrapolated a target.
So the target itself wasn't actually the variable being tested. They were just testing the drug, looking at the resulting cholesterol numbers, and backing into a recommendation.
Exactly. They made incredibly smart, life-saving estimates, but they were still just estimates. This South Korean trial was engineered to fill that exact void. They didn't want to test drug A versus drug B. They wanted to test target A versus target B.
Adjusting whatever medications were necessary to hit those numbers just to replace that consensus with definitive proof. So how did they build the trap to catch that definitive truth? Let's get into the blueprint. The methodology here is structured as an open-label superiority trial with a one-to-one randomization.
Right.
They took a pool of South Korean patients with established atherosclerotic cardiovascular disease, flipped a coin, and divided them into two camps.
And defining those two camps is critical because the numbers are the whole story here. The first camp is the intensive targeting group. For these patients, the protocol demanded physicians aggressively titrate their lipid-lowering therapies to achieve an LDL cholesterol level of strictly less than 55 milligrams per deciliter, or 1.4 millimoles per liter.
Wow, under 55. And the second camp is the conventional targeting group. Here, the goal was the older, more relaxed standard, aiming for an LDL level of less than 70 milligrams per deciliter, or 1.8 millimoles per liter.
Exactly. And to measure which strategy actually worked, they established a composite primary endpoint. They didn't just look at overall mortality. They tracked a very specific cluster of catastrophic cardiovascular failures over a 3-year period.
So things like death from cardiovascular causes, non-fatal myocardial infarction, non-fatal stroke.
Yes, as well as hospitalization for unstable angina or any revascularization procedure.
Okay, so if any of those events happened, it triggered the endpoint counter for that patient's group.
But hold on, I have to jump in on the methodology itself.
Yeah.
You mentioned earlier this is an open-label trial.
Yes.
The gold standard drilled into us is the double-blind, placebo-controlled study where neither the patient nor the physician knows who is getting the aggressive treatment. If everyone knows exactly what their target is, doesn't that introduce massive bias into the results?
It's a really common red flag to look out for, but we have to distinguish between subjective and objective endpoints here.
Okay, how so?
Well, if you are running a trial for a new migraine medication and your primary endpoint is self-reported pain levels, an open-label design is useless. The placebo effect will absolutely skew your data. But look at the endpoints in this South Korean trial. Death, strokes, revascularization surgeries.
Ah, right. Those are hard clinical events.
Exactly. The placebo effect cannot clear a severely calcified blockage in a coronary artery.
Yeah, you can't just positive think your way out of needing a bypass. Precisely. And more importantly, from a logistical standpoint, it is physically impossible to double-blind a trial where the entire mechanism of action requires hitting a highly specific biomarker target.
Because they have to constantly adjust the meds based on the blood work.
Exactly. The doctors have to draw the patient's blood, look at the circulating LDL concentration, and continuously adjust statins or PCSK9 inhibitors up or down to keep them in their designated zone. You cannot fly a plane blindfolded when your only objective is to maintain an exact altitude.
That makes total sense. You have to look at the altimeter. Which brings us to the reality of human biology. Drawing up a protocol that says, hey, force group A under 55 and group B under 70, that's easy on paper. Enforcing that on thousands of diverse human metabolisms over multiple years is a completely different animal.
It is, but the scope of the trial makes it highly reliable. They randomized 3,048 patients. That's 1,526 in the intensive group and 1,522 in the conventional group.
That's a huge sample size.
It is. And they track these individuals for a median follow-up at exactly 3.0 years. That gives us a tremendously robust data set, especially considering a relatively homogeneous South Korean cohort.
Right, which actually helps limit the noise from massive genetic diversity in lipid metabolism that you might see in a massive global trial. Here's where it gets really interesting. Let's look at the reality of the blood work.
Yes, the actual numbers.
The targets were less than 55 and less than 70. But the actual median levels achieved during the trial were 56 milligrams per deciliter for the intensive group and 66 for the conventional group.
That data point alone is an absolute masterclass in physiology. The intensive group had physicians throwing the kitchen sink at them, high-dose statins, ezetimibe, combination therapies, and they still missed their sub-55 target median by exactly 1 point, landing at 56.
Why is it so hard to drive it down those last few points? I mean, shouldn't more drugs just equal less cholesterol?
Because the body is a homeostatic machine. The liver synthesizes cholesterol because it's a fundamental building block for cell membranes and hormones. When you aggressively block that synthesis with statins, the liver responds by upregulating LDL receptors to pull more cholesterol out of the blood.
Oh, I see.
Yeah, there is still a biological baseline fighting back against the pharmacology.
Meanwhile, the conventional group, aiming for under 70, comfortably beat their target, settling at a median of 66. So practically speaking, we have two massive cohorts of people, heavily medicated, whose circulating bad cholesterol is separated by a median of only 10 points, 56 versus 66.
Right, a 10-point delta.
When you put it like that, it sounds trivial. Can a 10-point variance in a lipid panel actually dictate who has a stroke and who walks away clean?
That 10-point delta is the entire crux of the debate. If the cardiovascular system is relatively insensitive to LDL once you get down into the 60s, then those 10 points shouldn't matter at all. But the data reveals a completely different reality.
Okay, lay it on us.
Over the 3-year median follow-up, a primary endpoint event occurred in 147 patients in the conventional targeting group. In the intensive targeting group, that number dropped to exactly 100 patients.
So what does this all mean? Let's translate that into the statistical reality of the trial. The researchers utilized a Kaplan-Meier estimate of cumulative incidence, basically mapping out the survival probability over time, showing exactly when and how the two groups diverge in terms of their event risk, factoring in the varying timelines of when patients entered the study.
And that Kaplan-Meier curve is stark. The cumulative incidence of catastrophic cardiovascular events was 9.7% for the conventional group versus 6.6% for the intensive group.
That's an absolute difference of roughly 3 percentage points, but the relative difference is what really shifts the paradigm.
What's fascinating here is the hazard ratio, which was calculated at 0.67 with a highly significant p-value of 0.002. A hazard ratio of 0.67 means that the intensive group experienced a massive 33% reduction in relative risk compared to the conventional group.
That is wild. Think about that mechanism. It's like a major highway that's highly prone to devastating multi-car pileups because it's constantly congested.
Right.
You don't have to remove every single car to stop the crashes. By removing just a fraction of the vehicles, like the exact 10% that causes the critical bottleneck, you don't just reduce the traffic slightly, you cause the accident rate to plummet by a third.
That analogy actually maps perfectly to the biology of an atherosclerotic plaque. When you push circulating LDL down from 66 to 56, you are not just slowing down the deposition of new cholesterol. You're fundamentally altering the structural integrity of the plaques that are already embedded in the artery walls.
Wait, how does that work physically? I think we assume plaque is just, sludge sitting on the surface of a pipe, but it's actually inside the wall, right?
Exactly. It's a living, dynamic lesion within the arterial wall. It has a lipid core, which is essentially a pool of cholesterol and dead inflammatory cells, and that core is covered by a fibrous cap. If that cap is thin and the core is large, the plaque is highly unstable. It's a volcano waiting to erupt. If it ruptures, it triggers an immediate blood clot, which is what actually causes the heart attack. When you aggressively drive LDL down to 56, you establish a concentration gradient that literally begins starving the plaque of its core building materials.
So by starving it, the plaque shrinks.
Well, it's less about shrinking the physical size and more about changing its composition. As you deplete the lipid core, the inflammatory response cools down. The body is then able to reinforce that fibrous cap with collagen and calcium.
Oh, that makes sense.
You are turning a volatile, fluid-filled blister into a hardened, stable scar. That 10-point drop in circulating LDL is the precise threshold needed to accelerate that calcification and stabilization process. You didn't cure the disease, but you dramatically stabilize the lesion.
That completely recontextualizes the 33% risk reduction. It's not just a statistical anomaly, it's the direct result of physically hardening the vulnerable spots in the vascular system. But we have to address the biological cost of doing this. In medicine, there is almost never a free lunch.
No, there definitely isn't.
To push thousands of people down to an LDL of 56, you have to prescribe aggressive pharmacological interventions.
You do. Higher doses of potent statins like rosuvastatin or atorvastatin, frequently combined with ezetimibe to block cholesterol absorption in the gut.
Right, and heavier pharmacology universally means more side effects. The standard assumption is that if you hammer the body's cholesterol production that aggressively, you are going to see a spike in toxicity. Muscle myopathy, elevated liver enzymes, extreme fatigue. Did driving the LDL down to 56 wreck the patient's bodies in other ways?
It is the most rational concern to have when reviewing aggressive lipid-lowering therapies. But when we analyze the safety data in this trial, the paradigm shifts again. The incidence of pre-specified safety endpoints, the adverse reactions the clinicians were heavily monitoring, was fundamentally similar between the two groups.
Really? No massive spike in side effects?
Nope. The intensive cohort did not suffer a statistically significant penalty in muscle pain or liver toxicity.
So they secured a 33% reduction in major cardiovascular events without paying a massive toll in quality of life or systemic side effects. But I remember reading there was an anomaly in the safety data that completely flips the script on drug toxicity.
There was. This raises an important question because the researchers found a highly counterintuitive divergence in one specific biomarker. There was actually a lower incidence of creatinine elevation in the intensive targeting group.
Let's explore the mechanics of that because it feels paradoxical. Creatinine is a waste product from muscle metabolism, and we use it as a proxy for kidney function. If your creatinine levels are elevated, it means the nephrons in your kidneys are stressed and failing to filter the blood efficiently. You are telling me that the group taking heavier doses of medication didn't just avoid kidney damage, their kidneys actually performed better.
That is exactly what the data implies. The intensive regimen appeared to exert a protective effect on renal function over the 3-year period. To understand why, we have to look at the kidneys not just as filters, but as an incredibly dense network of microvasculature.
So if you have systemic cardiovascular disease, it's not just your heart that's struggling. The tiny blood vessels in your kidneys are likely compromised too.
Precisely. Atherosclerosis is a systemic disease. The same endothelial dysfunction and lipid deposition happening in the large coronary arteries is happening in the microscopic arterioles, feeding the glomeruli in the kidneys.
Oh, wow. I never thought about it like that.
Yeah, so by driving the LDL down to 56, the intensive therapy wasn't just stabilizing the massive plaques near the heart, it was improving endothelial function and reducing systemic inflammation across the entire vascular tree, including the kidneys.
So the aggressive statin therapy wasn't a toxic burden on the kidneys. It was actually restoring the microplumbing they need to function. It completely destroys the argument that lower LDL targets are inherently dangerous to organ function.
It absolutely dismantles it. It shows that in the context of secondary prevention, the damage caused by circulating LDL far outweighs the pharmacological burden of removing it.
Pulling all of this together, the clinical verdict of this South Korean superiority trial is unambiguous. For patients who have already experienced an atherosclerotic cardiovascular event, strictly targeting an LDL concentration of under 55 milligrams per deciliter yields a definitively lower risk of catastrophic cardiovascular events at 3 years compared to the historically accepted conventional target of under 70.
And it achieves that 33% relative risk reduction without compromising patient safety and potentially even preserving renal microvasculature. It is a profound piece of evidence that will force the medical community to aggressively update the definition of what constitutes a safe lipid profile for high-risk patients.
The takeaway for you listening is realizing how the frontier of medical science actually advances. It doesn't advance by blindly trusting historical consensus. It advances by designing rigorous traps to capture objective data and being willing to follow that data even when it demands we push biological limits further than we ever have before.
Exactly.
But this leaves me with a final, slightly unnerving thought that I want you to mull over. We started this deep dive talking about the illusion of mechanical precision in medicine and how difficult it is to locate the biological floor. This trial definitively proved that pushing LDL from 70 down to 55 provides a massive, life-saving benefit, stabilizing plaques and protecting organs.
Right.
So the obvious question becomes, what happens if we don't stop there? If an LDL of 55 is demonstrably superior to 70, is 40 superior to 55, is 20 superior to 40? With the advent of new injectable therapies like PCSK9 inhibitors, we now possess the pharmacological tools to drive circulating LDL down to single digits.
Which is an incredible development.
But at what point does the human cell finally rebel? Is there an absolute biological floor where the architecture of our cell membranes finally destabilizes? Or will future trials reveal that once atherosclerotic plaque is present, the optimal level of circulating LDL is essentially zero?
It's the exact question that pushes the boundaries of human physiology, and the answer will likely redefine cardiovascular medicine over the next decade.
Until those trials are published, keep questioning the consensus, keep looking at the mechanisms behind the data, and keep exploring the incredible, resilient machinery of your own biology. Thanks for joining us on today's deep dive. We'll catch you next time.